Hello and good morning, everyone. Thank you so much for joining ADAA and the All of Us Research Program's collaboration, Improving Healthcare Through Research, a fireside chat with the All of Us Research Program. We have Dr. Julia Moore Vogel here with us and our Chief Medical Officer. I would like to make a note that this webinar is being recorded and will be available on demand for all of those who are joining us live today. As we are live, we are welcoming your questions throughout the session. At the bottom of your Zoom screen, you will see a Q&A button. Please feel free to enter your questions there at any time, and we will answer them after Dr. Vogel's presentation. We are very excited. I would like to hand it off to Dr. Sanjay Matthew, who is IDA's Board Chief Medical Officer and Secretary. He will be our host today. Sanjay, I'm handing it right over to you.
Well, thank you, Sasha. And it's great to be here and great to host Dr. Vogel as she'll be talking about the All of Us initiative from NIH. And just by way of background, I would encourage everyone, certainly after this webinar, to read more about it on the website. There's allofus.nih.gov. And really the purpose, as she'll be talking about, is to invite at least 1 million people in the US to build a diverse healthcare database, and perhaps the most diverse in history, and to use this, leverage this extensive database to learn more about biology, lifestyle factors, and environmental mediators influencing health and mental health. And so we thank Dr. Vogel for presenting and really the partnership with our organization, ADAA, and acknowledging the role that our partners have in sort of helping our membership reach their full potential and ultimately leveraging this information to ultimately find cures for some of our most complex and challenging disorders, which is really the aim of our organization, ADAA. So with that, we welcome Dr. Vogel, who is the program director at Scripps Research, and she manages the participant center for the NIH-funded All of Us Research Program. So she'll be making a presentation, and then we'll have plenty of time for an active discussion. So I encourage you throughout the talk to put your questions in the Q&A function. Thank you.
All right, let me share screen. There we go. Okay. Hi, everyone. Excited to be here to chat with you today about the All of Us Research Program. You'll see at various points in the presentation, we'll have this QR code that you can scan to go to the website and learn more about the program. So one of my favorite quotes about the All of Us Research Program that really sums it up is what then President Obama said about the program when he was first announcing it. And so he said, this has the possibility not only of helping us find new cures, which on its own is very exciting, but also helping us create a genuine healthcare system as opposed to just a disease care system. So the idea here is to figure out how we can really be proactive about health. And we're doing that by building the largest and most diverse health resource of its kind. So the types of questions that we might answer are varied, very varied. We are really building a disease agnostic cohort that could answer many different questions. So we put a few examples in here, like, can we potentially predict antidepressant response? Can we prevent chronic pain that affects so many? Can we drive sustainable interventions that might support health equity? And many other questions. So then we can talk about what is the All of Us Research Program. It's a historic effort to gather longitudinal data from 1 million or more people across the US. Of that, we've already recruited 500,000. We're working to accelerate research and improve health. To do that, we need to learn about all different aspects of people's lives, their lifestyle, their socioeconomic status, their environment, their biology. Many different facets come together to make up our health. And what we really want to do is make that data available to all different researchers who can one day deliver on precision medicine or individualized medicine to improve care for everyone. There are currently over 3,000 researchers already analyzing the data, and they're doing this analysis across many, many different disease conditions. So not only do we have this data gathered, but we're already starting to deliver on the promise, and we saw the first publications on this data last year. The mission of the program is to really work closely with participants. We treat our participants as partners to nurture their relationships with the participant and make sure that it's really a mutually beneficial relationship, providing your data to the program and then getting information back from the program. We are delivering one of the largest, richest biomedical data sets out there, and we make a lot of effort to make sure that the data is kept as securely as possible. And this includes catalyzing an ecosystem of researchers, community partners, funders, all together working to make the All of Us research program what we want it to be. So that requires a lot of different organizations. And this is some of the 100 here. Scripps Research is up here, which is the organization that I'm part of that leads the Participant Center. And the Participant Center really works to reach out to individuals all across the country to make it possible so that everyone across the country can participate in the program. There are also a lot of healthcare provider organizations who catch folks as they're receiving healthcare to talk to them about the opportunity to participate. And then a number of different technical resources, those that are interfacing directly with participants, those that are storing the biosamples, those that are storing the data, and then those that are creating genomic data. So this is just a massive teamwork approach to be able to deliver on what the consortium is doing. So we're on our way to recruiting 1 million participants. We already have over 575,000 participants who have enrolled, 340,000 of whom have shared their electronic health records, 415,000 of whom have shared biosamples, including blood, urine, and saliva. And then, as we mentioned, over 3,000 researchers working on many different projects. We just called out here, there are 126 projects that mention mental health in their research description. And all of those descriptions are available online. And so you can go to the website, researchallofus.org, and look at any of the descriptions that are there, all of 3,000, and see sort of what types of research are being done. But you can see it's really quite broad across different disease types. And it's also really important to us that the resources used for health equity purposes. And so we see that 246 descriptions include discussions of race. And so looking at racial differences in our health. So building on that, we really want to focus on representing those who are historically underrepresented. So in the past, we've seen for both Black, African American, Hispanic, Latino, and other racial ethnic groups, they're really underrepresented in clinical trials relative to the general population. So you can see here, 13% of folks in the US are Black or African American, 5% of those in clinical trials self-identify that way, and 19.2% of those in the All of Us research program identify as Black or African American. And this is something we're really excited about, being able to make sure that the cohort is really reflective of the US population rather than skewed in some way. And so over 50% of All of Us participants have been historically underrepresented in biomedical research based on their race or ethnicity, and over 80% have been historically underrepresented in any category. So that includes, in addition to race, ethnicity, things like LGBTQ+ status, rural individuals, those with low socioeconomic status, and more. This representation is crucial to ensuring that discoveries are inclusive and beneficial across populations. So, when we think even in the genetic part, there are such differences between our genetics that if we don't include all populations, we might not realize that things are not relevant for one population rather than another. It also is a way to discover things like protective genetic effects that only exist in one population that we otherwise wouldn't have figured out unless we had an inclusive set. So this is really very broadly beneficial to be able to have this inclusive data set. So how the program works, there's a lot of text on this slide, but to give you a summary at a high level, the participants share their data is the first step. And so participants really get to choose how much information they want to share. We know some folks are more comfortable sharing different data types than others, and we want to make sure that there's full agency for participants to make those decisions. We keep the data in a protected space where only certain individuals can access fully identified information, a very small subset, but in general, the identifiers are removed before anything gets made available to researchers, so that we're having this delicate balance between making a lot of data available while protecting participant privacy. Then the researchers are able to study the data. Right now, it's open to researchers at nonprofits in the US, and we're working to make it available to both international institutes and for-profit institutes, because we know that a lot of innovation happens in the for-profit sector as well. And we want the resource to have as broad of a utility as it possibly can. The data set is very broad, and we'll talk more about that in a bit. And then participants get information back. So right now they're receiving information about genomic results, including ancestry, traits, and health-related results. And we'll talk more about those results in the future. And some participants are receiving Fitbits at no cost. This is to really expand on the data set to have things like resting heart rate and activity be able to be tracked by in those who wouldn't necessarily purchase a Fitbit for themselves. We also share information about the latest research to help participants learn about the research process and keep them engaged in terms of what's happening with the research. We also have researchers share discovery with the public, and we really aim to make these breakthroughs as equitable and inclusive as possible. So this is more information about the types of data that we collect. So when folks initially enroll, anyone over 18 can enroll, anyone that's not incarcerated over 18. And we are working on protocols to include children in the future. There's an online consent process and an online process to share your electronic health records, as well as consent to receive DNA results. You don't have to receive actionable genomic results, but everyone needs to at least indicate their decision about whether they want to receive it. Then there are a number of surveys about the basics, which is essentially demographic information about your health, your lifestyle, healthcare access and utilization, and then family history and personal health history. There are other surveys that we'll be releasing on an ongoing basis, and one that we've released more recently is the social determinants of health survey to help us learn more about different health equity. I would say inequity at this point, but help us make progress toward health equity. Also, we collect physical measurements at in-person appointments for those that come in person to provide blood and urine. And then if folks don't come in to provide blood and urine, or there's not a convenient location near them, we can send saliva kits to their homes. And that enables anyone across the US to be able to provide a sample for DNA sequencing. We also have the ability for blood and urine collections to take place at any Quest location nationwide. So that really has improved the reach. In terms of wearables and digital apps, folks can share information from their own wearable devices like a Fitbit to the program, or as I mentioned, some folks are also getting devices through their participation. So the magnitude of data that's available to researchers to me is really staggering. Almost 400,000 survey results, 300,000 physical measurements, over 150,000 genotyping arrays, and almost 100,000 whole genome sequences. Of note, in the 100,000 whole genome sequences, we've met that goal of having 50% of folks being underrepresented based on their race and ethnicity. And we'll also be adding to this result to these data in the coming months. And then also the electronic health records and the Fitbit data. We also have some COVID data in there, including data from 20,000 folks who have had COVID and responses about vaccine uptake, as well as the social determinants of health survey that I mentioned, including things like neighborhood safety, social support, discrimination, and food security. So we wanted to highlight the efforts that we make here in protecting data, keeping it secure and private. So one thing that we do is have extremely high privacy and security standards. So anyone that's going to be having participant information on their servers or in their hands has to go through a process of vetting to make sure that they have the capability to be able to protect it in the way that we expect. We also do a lot of de-identification of the data. So instead of having names and dates of birth, there are participant ID codes that are associated with the individual to help protect against re-identifiability. It's also stored on protected computers. So all the computers have, certain security standards as well as specific practices that the team has. And participants have access to their information that they provide. So they can see what information am I providing, and in the unlikely case of a breach, how would I feel about that information being exposed? So one of the more fun things we're doing is returning genetic results. So these are fun things like ancestry and traits. Traits can be things like, do you love or hate cilantro, which people might know about themselves, but they may not. And we recently launched health-related results. So this includes pharmacogenomic results, which is certainly relevant for many antidepressants, and then also disease risks from the ACMG 59 variants, if anyone's familiar with that guidance, which includes predispositions like if you have a BRCA1/2 variant, you're much more likely to contract breast and ovarian cancer. Importantly, all of the disease risk variants that are returned are things that folks can do something about. So there's care that they can seek to try to minimize their risk. We also provide genetic counseling for anyone that receives disease risk pathogenic variants so that they can think through with a really well-informed individual how this is going to affect their care, what their next steps should be, whether they want to share this information with their doctor, whether they want to share this information with their family members who might also be impacted. So we really want to make sure that participants are supported through that process. We are, as I mentioned, Scripps' role is to make participation available nationwide to everyone. So we had a lot of COVID survey results that we worked on earlier in the pandemic. I mentioned receiving a Fitbit and genetic results. Donating blood can happen both at these Quest locations nationwide, but also we're working with a lot of different blood banks across the country. So this is an interesting collaboration where, folks can donate blood to be used for transfusions. And when they do, there's this little pouch on the side that is used for infectious disease testing. But usually there's some extra blood in there that isn't used for infectious disease testing and otherwise gets discarded. So we have a program now where if folks consent ahead of time, we can use that blood for the All of Us research program rather than having it be discarded. Then I also mentioned the at-home saliva option, making it much more convenient for folks to share their sample. So going through a few of the results that we've had, one of the really interesting ones was at the beginning of the pandemic. So we were collecting blood, throughout the country for many months leading up to when everything shut down in March of 2020. And what we were able to do was look back in time at the samples and say, hey, when was the first time that we saw COVID antibodies? So we weren't, collecting the samples thinking that this is what we were going to look for, but we were able to use the resource to retrospectively look back. And what we saw was that in 5 states, folks actually had antibodies in our resource before the first case was ever reported in those states. And of course, it takes a few weeks to create the antibodies from the time that you get infected. So this really adds to the information supporting that COVID-19 was actually here in the US in December, and we didn't realize it because we just weren't looking for it at that point. And that's really important, I'll say, to individuals, especially with long COVID, which I'm also very active in the long COVID patient and research community. Many folks contracted long COVID before there was broad testing available. And so it's been very difficult for them to get care or even be believed that they were able to contract it that early. But this really adds to the evidence that, yes, COVID was circulating at a low level much earlier than we initially appreciated. We also wanted to highlight this research result on discrimination and depressive symptoms. And so this was looking at information in the COPE survey, which was distributed during the pandemic. And they were looking at whether discrimination during the pandemic would be associated with moderate to severe depression and or suicidal ideation. And what they found was, yes, there was an association between discrimination and both depressive symptoms as well as suicidal ideation. And so that, that's a really important result in terms of the very real impacts that discrimination can have on folks. And there are a few other highlights from this survey pictured here as well. So a little information about what can happen by participating. The goal is to help future generations. We know that health research takes a long time to generate the real most impactful results that we want. And certainly if a drug target is developed and we have to go all the way through the drug development pipeline, that takes a long time. And so we can think of this as an investment in the health of future generations, as well as hopefully delivering some results in the nearer term. Fueling health research in general, as we mentioned, there's over 3,000 studies ongoing. And then learning about your own health through things like return of genetic results. And we hope to have much more return of information for participants in the future. And then fueling COVID-19 research. I know a lot of folks are feeling kind of done with the pandemic, but there's still a lot more that we have to learn about the long-term effects of COVID that this resource can help us learn about. So I'd love to go to discussion if folks have questions.
Great. Well, thank you, Dr. Vogel. And yeah, we'll proceed. So I encourage anyone to type in the Q&A box if you have questions. And we do have one question to start off with. Just a note that this was an incredible program. Do you think that providing individual participant results makes people more likely to participate in the study? And is that the main reason for this particular model of research?
The main reason is really to be respectful of participants, to treat them as true partners in the research and not just sort of subjects is the term that used to be used, where it's like, the person is coming in and you're sort of using them for the research. We really want to have a mutually beneficial relationship with our participants as we go along. And so our feeling is if we have the information and it could help the participant, we should share it with them. It also has the benefit, of course, of helping with engagement and making folks feel more included, but that's, I'll say that's a secondary effect. What we really want is to have transparency with participants and share information, have a really good stream of communication between us.
Great. So the question comes up about participation and how an individual can actually participate in this program. And when you've made the list of organizations that are part of the participation centers, it was listed CVS and Walgreens as the partners. So what would be the practical aspect of that? Could a patient just walk into a CVS and request participation? How would they go about that?
Yeah, we're moving toward that. I'd say we're working on that, but we're not quite there yet. What we do right now is CVS and Walgreens help spread the word to their different customer bases and the lists that they have to let folks know about the program. We don't have the in-person component at CVS right now in general, or Walgreens. In general, you have to go to the website to do that, and then we'll let you know what different components you can do at different places like Quest and others.
Great. So what would you suggest the best way? So if many of the folks in ADAA are practitioners, see patients sort of every day in their offices, and what would you suggest the best way for a patient to get involved with this program and participate? Would it be just to come onto the website, or what would you suggest?
Yeah, the website is the best resource, and we can certainly send around flyers for folks to be able to hand out to patients so that they can have a little bit more information before they choose to go to the website. There are also, let me see if I can get back to the slide, a number of healthcare provider organizations that have in-person appointments as well that folks could refer patients if those organizations are in their area. So they're kind of organized here by geographical area: California, Illinois, New England, Transamerica is sort of the Midwest, New York Consortium, et cetera. I don't have to name them all, but you can see that they're spread across the US. And so if they happen to be in the near those organizations, they could have patients go there and then ask about the program there to have an in-person component. Also on the website, there is a support center that's available by phone, email, and chat. If folks have any questions, they can reach out there and it's always live humans talking to you to answer any questions that they might have.
So any question, please put in any questions in the Q&A.
Yeah. Hi, Sanjay. I'm also going to hop in with a question. ADAA has a fairly large student population. How might someone who's a postdoc or a research assistant learn more about this or get involved or kind of implement the foundation of including DEI in the program in their research?
Do you mean in terms of accessing the data?
Yeah.
Yeah, absolutely. So they can go to researchallofus.org. That's the researcher facing side of the website. And so what you do there is you can create an account to be able to access the data. There's different training that researchers go through to make sure they understand, what stigmatizing research is, to make sure that they don't do stigmatizing research, and different things that they need to do to protect the data in terms of what they can and can't share outside of those within the collaborative space. None of the data can be downloaded, for example. It all remains in this cloud workspace. And there's also a lot of tutorials there to help folks learn how to analyze the data there. So it's available through R and Python right now, so it requires some coding experience, but there's a lot of template code that can be utilized as a starting point to be able to more easily access the data. And I'll also say the DRC Data and Research Center, which is down here at the bottom, has a great support group as well. So if folks are in there, trying to analyze the data and they're running into any issues, you can always reach out to the DRC and they'll help you through it. And it actually helps the DRC too, because they're learning about what additional support or tools or videos that folks might need to be able to do the research there.
Thank you. And if someone is looking to get involved in the project or support you in in some way, what would be the best way to do that?
Yeah, I would say helping with recruitment is one of the most important things at this point. So we're halfway to our 1 million. I think, with anything, the first half is the low hanging fruit. The second half is harder. And so, especially making sure that we have that representation of the communities that have been historically underrepresented in biomedical research. Anything anyone can do to help us with that, we certainly welcome. The other thing I think is a lot of times providers can be trust conveyors, essentially. If someone hears about this from a provider versus just learning about it on the website, or even from Walgreens or CVS, sometimes having that personal contact from someone that they trust to be able to hear about it and ask a couple questions, or at least learn where they can go to get their questions answered, can be a really helpful way to learn about it and feel more comfortable sharing information.
Have you been experiencing difficulties with mistrust in communities that are generally misrepresented or underrepresented?
Yeah, absolutely. I think it's something that all clinical trials and research studies face. There have been a lot of historical transgressions by the research community, the Tuskegee syphilis study, how Henrietta Lax's cells were used, et cetera. There are so many things that haven't been done the right way. And there have been a lot of reforms in the research community and a lot of policies, I'll say, put in place to make sure that we don't do that again. But it's very well earned mistrust that, you have to sort of prove that you're trustworthy before someone might feel comfortable sharing their information. The other challenge that we have is that it's a NIH funded project. So it is run and funded by the government. And there's a lot of government mistrust in different individuals, I'll say, for different reasons at different points in time. And we totally understand that as well. One of the important pieces is the data is actually owned by Vanderbilt University at the Data and Research Center, not the federal government. And so that offers a little bit more protection. We also have a certificate of confidentiality so that if there's a law enforcement request for the data for any reason, we're able to use that certificate of confidentiality to protect the data and not have to share it. And this is important, especially with genetic information. People see where ancestry databases are being used to identify criminals based on DNA samples from long ago, and they worry about providing DNA for that type of, based on that type of concern that a third cousin could somehow be indicted based on that information. And this resource is not going to be used in that way. In a similar vein, the resource is not going to be sold for-profit purposes the way that some genetic databases are. It's really meant to be used only for the public good to, do the best we can to develop better treatments and better cures and more proactive care.
Dr. Vogel, could you walk us through the process for sort of genetic counseling, if there is something like that? So
yeah,
a patient receives these results, and then how are the results explained to the patient?
Yeah, that's really important. So for the, let me see if I can go to that slide really quick, the genetics slide. For the actionable results, like the BRCA1/2s, the results are only returned through a discussion with a genetic counselor. So the pharmacogenomic results and ancestry and traits you get on your own, just sort of emailed to you. Well, you get an email and then you log into the portal because we want to keep it secure. But the disease risk results, you get returned through a genetic counselor appointment. So actually you would get prompted to schedule an appointment with a genetic counselor before you're told what the results are. Some participants may realize that this means they have a significant result and some may not, but you get that support throughout the process. So you have the results explained to you in this appointment, and then at any time you can call back if you have any questions. And actually that applies to any participant. If they're going through the DNA consent process and they're not sure if they want to receive these results or not, they're not sure about the implications, anybody can call the genetic counseling resource, which is run by Color Genomics, which is a genetic testing and public health company. And So anyone can call and get information from the genetic counselor, but for those that are having these disease risk, we have a specific appointment for them to learn about it, and then an open invitation for them to call back anytime. The other thing I'll mention is the results are first returned as a research grade result. So it doesn't go in a medical record. We don't share it with a physician unless you ask us to. It's really your decision what you want to do with that information. If you want it to be a clinical result, then for at no cost, the program will do a clinical validation for you. And so that at that point, it could go in a medical record and it could really be used to guide your care in a more specific way. And we thought that was, it's an important nuance for those that maybe that want to be able to make their own decision of, do I want to share this with my physician? Do I want this to be part of my official record or not? Especially because there are some states in which long-term care insurance and life insurance can be affected by having these results. And so if you want to keep it in the research space where no one ever knows about it and, take your own actions outside the medical community, you can do that. If you want to put it into the research space, then that's your choice as well. The other thing I'll mention is Color offers discounted rates for clinical tests for family members of someone who has had a positive result. So if you get a pathogenic variant and you want a family member to get tested, but they're not comfortable joining all of us, or they don't want to wait for all of us to generate their result, they can go to Color and get a discounted test, which is a really kind thing of them to do, I think.
Great, thank you.
Mm-hmm.
I'm going to allow everyone to have a few more minutes to submit some questions, but as we do have a large clinical and mental health research audience. Can you speak to how this might impact mental health research particularly?
Absolutely. I'm really excited about that because I think mental health diagnoses are some of the most misunderstood conditions. And I think there's so much that can be done in the research. And so the way that we're approaching it really is letting all of the researchers out there, right now in the US, but eventually in the world, come to the resource with their questions. And so we really want the best and brightest to bring their best ideas to this cohort and be able to discover whatever they can discover with it. Right now, that's all based on the data that we've already collected. Let me see if I can navigate back to just show those data types again. But in the future, we will also be offering ancillary studies. And so that's the idea where if you want to do a disease-specific study that requires asking new questions or even doing a randomized control trial for a treatment, we'll be able to run those through all of us as well. And so I'm really excited for that to come to fruition. And I think that is where we'll really be able to see changes at the practice level where, we can run more proactive trials and really affect people's healthcare that way. So those are in the works, not quite ready to be rolled out yet, and they'll start through NIH-funded studies. But I'm really excited for those to be able to use this resource to have more diverse clinical trials. I think will have a big impact on how we deliver care in the future.
Related to that with the mental health, could you give some examples of some of the ongoing projects in the mental health area?
I don't have them off the top of my head, but we could click on the link and see together. Let's see. 1 second. All right, I'm going to share again. One second. All right. So we have 140 mental health projects. One is about isolation, mental health, and the SGM population. So looking at LGBTQ folks. Social determinants of health and psychosis. Transgender structural stigma. A lot of sexual and gender minority pieces here. Another one about SDOH, looking at the Hispanic community. Intergenerational trauma and stress. Wide variety. ADHD and diet.
So quite a wide array of topics, which is very exciting, and I'm sure there'll be more as things progress. So so you're more than halfway to the million patients. Is the plan once you get to 1 million, the project would stop, or are there plans beyond that?
It's meant to be a longitudinal resource. We're hoping it's something like the Framingham Heart Study, which has been going on for generations now and delivered, really foundational things in the cardiovascular space. That requires ongoing funding from Congress, but that's the goal, is to have, right now there's funding for a 10-year project, which we're 5 years through. But the goal is for it to be really longitudinal and look all across the lifespan. And I think that's another really crucial piece. It's not that people are either well or unwell and that's it. And even though that's how we treat them sometimes in individual studies, it's that everybody has a spectrum of their health and it changes over time. And that temporal piece is it something that we can really learn about, especially if we think about mental health diagnoses, is there something that we could have done to intervene earlier that could have prevented it from getting to, a really difficult spot? Would be a really interesting thing that we could learn about from this resource.
Great. Any other questions? I don't see any in the chat. So if not, I'll hand it back to Sasha for some concluding remarks.
All right, put my camera there a second. Thank you so much for joining us today. We do have the All of Us Research Projects link on our website. This will be available online, so if you'd like to request the recording, please email us, and I'm sure you can go to the website with any questions for the All of Us Research Program. Dr. Vogel, thank you so much for all your important work. I think this study can make a real impact, and we are so appreciative of you joining us today. Sanjay, thank you for being our wonderful host.
Thank you, Dr. Vogel, for your time.
Thanks for having me.